This talk was prepared with two of my fellow, Nika and Kamal. Here my disclosure. So the first point when we began to use it was to evaluate the acquisition time, and we were really surprised, despite the high quality of image, to have a very short acquisition time for both macular and periphery, widefield and macular field, 6x6, less than 10 minutes, and 20/24, less than 30 minutes. We evaluate different types of CNV, and we can show very precisely the borders of the lesion, the limits of the lesion, and the flow in each patient. So I will show you consecutive cases. Here another example of a fibrovascular lesion, type 1. One more type 1 CNV with the borders of the lesion well defined. And we can distinguish all parts of the lesion, the big trunks, the anastomosis, the little tiny ramification, again in the type 1 lesion. Here was a polyp. We were surprised to see very well the polyps and the branching vascular network that is adjacent to the polyp. Here, branching vascular network. So here we don't see the flow. We just see an hyperreflective signal. What we call it a popcorn effect, because there are a lot of things, but there is no CNV. If you have a look, you don't see any CNV, any vessel, just this kind of hyperreflective. This is not CNV. It can happen that in the middle of a popcorn effect, we see something very shiny, very brilliant, hyperreflective lesion. And in the middle of this lesion, we can observe a type 3 or a nascent type 3 lesion. And this is significant. Here is another example of type 3 lesion. When we see this, so we cannot miss it. When we see these hyperreflective points, hotspot, this is a type 3 lesion or a nascent type 3 lesion. It helps us to have the detection of this lesion. This is before and after the one single intravitreal injection of anti-VEGF, and you can see that it's extinguished. We cannot see it anymore. We had two zones of type 3 on this patient, and after the lesion, it disappears. Here is a mix of type 1 and type 2 lesion. Again, a type 1 fibrovascular lesion, and I'm always fascinated by the delineation of the vessel. We can really draw the vessel on that without any artifact. One of the limits of OCTA in CNV is to see the CNV when there is a big PD over 250 microns. And with the TowardPi, we were really surprised to see the vessel, whatever the size and the height of the PD. Another example, here is a polyp lesion. So we try to colorize this black and white image by colorization, and we have gorgeous images with colorization. The next step was to try to quantify the CNV. So we can have different quantification. The first one is the vascular density analysis that is automatic. We don't have to make measurement. It's already on the process on the imaging. Here, the vascular density analysis of the deep vascular plexus, of the choroidal vascular plexus. Here is a follow-up of CNV with the quantification of the central retinal thickness. Here, the quantification of the superficial vascular plexus, the follow-up. We see that for CNV, it does not change before and after the treatment. And we evaluated in different kind of condition. Here, the follow-up on ultra-wide field, the superficial plexus vascular density. So after having the color and the numerization of the image, we try to see if we can have a modelization of the polyps and to see particularly where are the polyps, the size of the polyps. It's really impressive for detection of polyps. We don't need actually any more ICG for evidence of the polyps. One more, and the branching vascular network adjacent to the polyps. So one of the limits of the OCT is the detection of the polyps. And ICG is really the gold standard, but with this imaging we can see the polyps with a great definition of the polyps. So it really helps for the diagnosis of the polyp and to see the limits, the borders of the branching vascular network adjacent to the polyps. Here is the PED and the polyps on the border of the PED. PED appear as a core, and we can see on the border of the polyps. So just, I couldn't resist to have a couple of images of the periphery here on a diabetic patient. You can see the vitreous interface, the OCTA and the slab and the OCTA en face. Evidence with a wide field, the area of ischemia and the preretinal neovascularization. One more thing, last thing, this study driven by Alexandra and Nika about what we found with this device was the limits of the non-perfusions on wide field OCTA. In our practice, we don't perform FA on young RP patients. We know the vessels are attenuated, but we don't know where, we don't know how to quantify, and this was really relevant to quantify the limits, and here we compare the fundus, the FA, and the wide field OCTA. It's non-invasive, it is acceptable by the patient, and we can see the non-perfusion or the hypoperfusion on this patient. We also analyzed the vascular density, choroidal density, but also the retinal vascular density in this patient. Thank you.